In the not-too-distant future, a revolution is brewing, one that will change the very fabric of our existence. It's a tale of cells that hold the key to unlocking the mysteries of life itself. Let us venture into the unknown, for in this age of stem cells, anything is possible.
I've seen some beautiful flowers.
Well, thank you for tuning in to another episode of Stem Cell Revolution.
Here we are.
We are still on this topic. I feel like we're almost at the end. We're halfway exactly today. We are picking up from where we left off. We were talking about the 4 set of criteria that will ultimately define your cell product as either a human cell tissue product or an actual biological drug. And so those 4 category, again, Jan, would you like to recap?
Sure. We have minimal manipulation, homologous use, no combination with other articles, and no systemic effect. And to recap a little bit more, so minimal manipulation, we'd previously discussed, so check this episode out if you haven't seen it, that this means that cells or tissues must not be more than what FDA articulates as minimally manipulated. That is, for structural tissue, processing can't alter the tissue's original characteristics relevant to its utility, whether that's for reconstruction, repair, or replacement. For cells or non-structural tissues, it means that the biological characteristics are unchanged. That second criteria, again, we've got a full episode, so check it out if you haven't seen it yet. Homologous schmologous. The product must be intended for the same basic function in the recipient as it had in the donor. Today, we're going to talk about that third thing, which is no combination with other articles.
Thou shalt not mix.
Thou shalt not combine.
Now, I was thinking, how are we going to talk about those for 30, 40 minutes? It's relatively straightforward. Mm-hmm. FDA says you cannot combine your cells with anything else. But it's not just anything else. There are exceptions. You can combine with water, also crystalloids, or a sterilizing or preserving agent, because of course a lot of these products are preserved, so they need to be sitting in some kind of preservative. So as long as the combination of these things don't cause another safety threat, it should be okay. So that's what you're limited to combining.
Well, it sounds simple on the surface, but we know there are complexities, or it wouldn't be a criteria, right? Out of a seemingly infinite number of things you could articulate, why this point? I mean, what's a real world example of combination?
Well, let's talk. Let's start with examples that are clear cut. Let's start there. That's always easy to start with. Okay. Let's say I have stem cells. And I mix it with some kind of anti-inflammatory drug. Okay? Drug mixed with cells is?
A drug.
Yes, a drug. If you combine, let's say you have tissue and you want to enhance that tissue. Mm. So remember in the last episode, we spent some time talking about the amniotic membrane, how you put a piece of tissue in a certain spot, hoping that it'll do something. Well, most of that time, that innate tissue may not have the capabilities we want, and so we want to add other growth factors, so other stimulus, essentially something to catalyze or stimulate the stem cells in your body to home to that area and to begin the regenerative process. So if you were to combine a tissue with those factors even, because factors, depending on where you isolate them from, can be drugs or not regulated as drugs. So even if you had 2 compounds that were not drugs and you mix them together, you would get a drug at the end. Yes.
Can we talk specifically about exosomes? I think we have seen over the last couple of years an increasing amount of research and news and papers and Reddit subthreads about exosomes. So where do they fall in this combination conversation?
We need to have an entire episode dedicated to exosomes, the world of exosomes. I have a lot of feelings about exosomes, and for our audience, what exosomes are a subset. So when stem cells are growing, they secrete, or in the lab, they're in the lab setting, they secrete a whole slew of factors. They're also sitting in some kind of a medium that allows them to proliferate or to live. And so as it is excreting, eating the food and excreting stuff, that concoction of what they excrete, a small subset of those secretions are exosomes. Now you would say, well, what defines exosomes? That is precisely the problem. There's no clear definition because it's actually humanly impossible. And I say impossible because we haven't identified all the compounds that these cells have secreted. So we do exercises like proteomics assays, like mass spectrometry, for us to see what's in there. But to make sense of what's in there, it is no different than the human genome. We spent all this time mapping out the human genome, and we did, and we were applauding ourselves like we did this. But to understand the way the genes work together is very complex, right? Yeah. So same thing. The cells are secreting many more things than we know, than we can imagine. And now we decide we're going to classify by size these very small molecules. We're going to call them exosomes. That is just simply, that's the definition of what exosomes are. So it is arbitrary because it depends on, every lab has their own way to isolate exosomes, right? Think about it. If you were to, and how there are many different techniques to isolate exosomes, but if you were to like centrifuge them, for example, you spin them down really, really, really fast, and that's how you separate the growth factors and the proteins that are in there. If one lab centrifuges them 10 minutes longer or at a higher speed, arguably there would be different little tiny particles in that pellet. So that means that there is a consistency issue, right? And we can't just define all these things as exosomes. I mean, this is the art of characterization. Characterization is wanting to know exactly what is in there. And this is important in having the conversation of exosomes as a drug. If you are saying that exosomes are so efficacious, then what compounds are causing the efficacy? That's very hard to answer. So again, we're going to get way too technical. So we'll talk about that on another day.
We'll have a full conversation, and I really look forward to it because there's a lot there.
Exosomes are not stem cells. That I want to make clear.
So what happens, what about these products where exosomes or growth factors, which we mentioned, enzymes, which we haven't directly but are in that same kind of family, if you combine those with a cell therapy, which we're seeing done, is that considered combination that then kicks it to the drug category?
According to FDA, yes. Okay. Even a device. So let's say you take a bone graft or some kind of scaffold. Let's say you need cartilage. We used this example last episode. Let's say you need cartilage in the knee. You have a scaffold, and now you put growth factors onto that scaffold. Well, the scaffold was approved as a device, so that's safe to go in. And this is technically, the growth factors are technically, could be an HCTP on its own. But once you combine them, they instantaneously become a drug. Yes. So who gets in trouble here? The manufacturers of both products are allowed to do that. It's the moment that somebody combines them. Somebody combines them. So in this example, it could be the clinics. This is why the clinics then get hit with these warning letters telling them that they cannot do this. So if, I thought about this with respect to timing. If it's not okay for the doctor to combine them, then it's not okay for the manufacturer to combine them. If the manufacturer combines them, then they would have to submit a new drug application. That's what would happen. And everyone knows that a new drug application takes years and years and years. At today's estimates is about 12 years, and $2 billion later, then you have a drug. So this is very expensive, right? It's a very expensive endeavor to get a product to the finish line in the drug world. So as much as possible, you want to get it to the market in not the drug arena. So you have to sell them separately. Can't put them together. Yeah.
So what happens, you mentioned warning letters. The warning letters that you see, if you Google FDA warning letters on the internet, that sort of thing, you'll turn up some scanned and sometimes grainy pictures of these warning letters. And they generally say, hey, this product is actually a biologic drug. It has to be regulated accordingly. Stop doing what you're doing, right? What are the real world implications of warning letters? And what happens other than a letter to enforce these, arguably murky restrictions and considerations?
So what normally happens is there is an enforcement. So a letter is sent, and that's their act of enforcement. There's really nothing after that. You don't really see people showing up and arresting doctors. That back end tends to, not happen. If there's a class action lawsuit that gets filed, or I've seen lately states suing certain practices or companies for selling these kinds of products, but that's more like on a mass distribution. Individual clinics that get these letters, they tend to resurrect themselves with different names. So you see them all the time. Even in Houston, I have noticed all these regenerative clinics, and the next time I drive by, they're gone. And then sure enough, they'll come back. Same people, you recognize the same names. They come back with a different name, and they keep resurrecting themselves. Yeah.
As an aside,
yes,
my favorite is when they write books. And the book has, 3 clinics ago, and that these same actors have moved on to other clinics. And, it's something that's specific to the industry. We can kind of shake our heads at, but realistically it has an impact, because it seems like, from a layman perspective, a system that holds back manufacturers and clinicians who are abiding by the rules, right, while letting those who aren't play however they want on the playground, which then begs the question, what's the purpose of regulation that isn't enforced? It doesn't seem to have any teeth. Why do we have it? Do we need it?
So I think we have to put our common sense hats on, okay? And, a good patent attorney will tell you, patent something if you're only willing to enforce it, okay? So in this scenario, if we're going to generate rules, and again, this is a good opportunity to be talking about this, because if there is going to be a regulatory overhaul, then we really need to think about these concepts. What rules do we really want in place? Because we have to be willing to enforce them properly. Can't just arbitrarily make up rules. Case in point, thou shalt not mix. If a physician finds a way to enhance the efficacy of a product, one can look at that as innovation. To assume that that is dangerous and say, you can't mix, we're just not going to let you mix, is not, I don't think, is the way to approach this. Thoughts?
Well, I mean, I think when you're talking about physicians innovating, I saw patient faces flashing through my mind because, I mean, we've had the privilege of personally knowing and receive the therapeutic manufactured here at Hope Bio, people who are undergoing chemo, people who are pursuing conventional medical treatment in conjunction with receiving cell therapies at the discretion and advice of their physician. And quite frankly, we're seeing phenomenal results. And so this idea that cell therapy, has to be a standalone, or regenerative medicine has to be a standalone, or conventional has to be a standalone, right? It seems to be isolating and siloing therapeutics and treatment pathways that can be combined in innovative ways. The other fact of the matter is, degenerative disease is highly individualized. So when we tell physicians, who, by the way, from a regulatory point, are subject to their own code of ethics, their own oath, their own regulations, when we tell physicians or medical providers, thou shalt not combine, we're attempting to disavow, I think, or ignore the individualized nature of the disease and condition itself that needs to be treated and relieved, to the detriment of the patient, who is a real person sitting in a chair facing a real healthcare crisis, right? And again, from a regulatory standpoint, so we have clinical and medical regulations and constrictions that do have teeth because you have to be licensed to practice in the United States. We have consumer protections, right? And I'd like to talk a little bit more about that because there are some very confusing things you see, if you just start looking on your own. We have consumer protections, right, that do have teeth, usually financial teeth. So what is the purpose of the additional layer of FDA regulation, which seems to have no teeth?
Well, I think we'll hit this subject towards the end, like what are the solutions when we talk about the solutions, and the real question, like, do we need to be regulated in everything, or are we capable of self-regulation? Now, there are examples of this, so we're not just making this up.
Let's talk about something that's confusing first before we move to what would be
good.
clarifying. Super confusing to me, DMSO. Super confusing. What are we even doing? What are we not doing? Why? I mean, it's different every place you see it.
Okay, so DMSO is a very interesting conversation because DMSO is a very common agent to add when you're like freezing cells. So it's a cryopreservation. So in very cold temperatures, you want cells to be stable. And DMSO has been a long time, used compound to stabilize cells through the freezing process in extreme temperatures. And DMSO has various identities. I was actually looking up what it was approved for, because I do know that DMSO is a drug. So remember, DMSO as a cryopreservation agent is allowed because you're allowed water and preserving agents to be mixed in with the cells, and that won't be crossing the line. But at the same time, it says you can't mix it with a drug. So DMSO is actually an FDA-approved prescription drug for, it's a tongue twister, interstitial cystitis. What is that? Bladder pain syndrome. So it is a drug. Now, if you were to say, I'm going to take DMSO drug and mix it up with the cells, then it will instantaneously be a drug, right? Mm-hmm. Let's say you were actually going to use the cells for interstitial cystitis, then you're in fact mixing two things that have an efficacious outcome. So that would be a drug. In DMSO as a cryoprotectant, if you were to say, I'm mixing this as a cryopreserving agent and with the cells, then it would pass, no problem. It is actually also an industrial solvent. So they sell it on the shelf. Okay, they sell it on the shelf. It's used in paint removers, industrial cleaning, and chemical extractions.
Well, and according to Reddit, some people use it topically for pain relief.
Oh, I knew a man who did that, who would carry around DMSO everywhere he went. And he swore by it. And so anyway, how do you have the same compound regulated in 3 different ways? So to back up, in the United States, you could have a compound that is sold as both, as not a drug and as a drug. Case in point, well, let's use an example of vitamins. Okay, I can't think of any vitamins that are drugs, but actually, there have to be vitamins that are drugs. Let's look that up.
So vitamins can be approved as drugs if they're intended to treat a disease.
So
it's approved vitamin C as a drug.
There is?
According to the AI bot answer overview on Google.
There is vitamin C that is a drug.
The FDA has approved vitamin C as a drug.
Okay. All right. So case in point, vitamins. Vitamins are, you go to your local pharmacy, you find vitamins everywhere. You notice on the labels, it doesn't tell you what these vitamins do. You're supposed to know this walking into the store. And it's that claim label. Now, there are vitamins that are sold as drugs. We just checked. High-dose vitamin C was approved as a drug, perhaps a certain brand of it, because it made a claim. So if you make a claim that this vitamin C is going to get rid of your cold, that is a therapeutic claim. So suddenly you go from being not a drug to a drug just by what you say.
So then the label is the trigger for the regulatory action, not the product itself.
So that question, it really starts to hit on, well, where does safety fall into this? If we are making a case based on a label and a claim, it's almost like a marketing claim, then safety is sort of put to the side. Like that doesn't matter because it's the same compound.
Well, and that to me seems like a consumer protection issue. I mean, we saw that with the nicotine industry, tobacco industry and nicotine claims, and we've seen it with alcohol in certain states. I mean, that seems like a well-trod consumer protection path as opposed to a safety one.
Yeah. So I would think that if I were a developer wanting to make a claim and deciding that I'm going to put this on the label because this is the claim that I would like to make, I should stand by that claim because I can be sued for not living up to that claim, right? So that should be fear enough, especially in this litigious society that we live in, that we should be conscious about what we're doing and what we're making and ensuring that we make what we say we're making, right?
Yeah. It should be.
Well, okay, so that is the confusing world of DMSO. And all this to say, with DMSO, it goes back to the claim. If the claim on the use of the DMSO is it was just used as a cryoprotectant, then so be it. Yeah. And, there are other examples of this that make this regulation very confusing. And so rather than, again, fixing on the action of mixing, it should be what? How do you resolve it?
Well, I mean, there are industries that have, from a regulatory standpoint, I think arrived at good answers. And, interestingly enough, we talked about self-regulation before. I think the most prominent example of self-regulation in an industry probably most people have heard of is IVF. IVF involves significant lab manipulation. You've got two totally different cells coming together. That has been deemed, as we talked about in a previous episode, so again, catch them all if you haven't yet, but has been deemed not a drug process. It's been deemed an HCTP. So it is not subject to the type of regulation that we are talking about. And yet the industry, the current estimates are that as of 2023, more than 12 million babies globally have been born as a result of this lab-based process. So, what are your thoughts about that? How does that a model for what might be possible in regenerative medicine and cell therapies?
So, yeah, this is a great example of what happens when regulation doesn't exist. IVF actually started, the first IVF baby was born in 1978. And the HCTP regulations came 23 years later in 2001. So that's a huge gap in time, right? Where regulations just did not exist. So nobody was looking at human cell tissue products. So it was effectively the wild, wild west. Now, if it wasn't, would we have figured out IVF? People argue that we would have never, if we had all these regulations in place, it would never happened. So when you are looking at whether that industry was able to survive and excel and grow, I think 12 million babies is probably a good indicator that they did well and they figured out what needed to be done to ensure that the practice of IVF could be done safely and effectively. So a recap on IVF, as you said, you have two different cell types coming from two different people. So they're clearly cell products, but they are sent to a lab. And when they're sent to a lab, now it takes over 24 hours. In the lab setting now, you have manipulation that occurs. Now, you can't argue that it's not manipulation because you're putting two cell types together and effectively creating a totally different thing, right? the totally different outcome and putting that back into somebody. Now let's talk about side effects, right? The side effects of putting that into one of the individuals or to a third party, there are actually possible side effects from that. So you have, multiple births that can occur. You can have congenital issues that can arise. And so even though these risks exist and they are clearly going above and beyond the HCTP requirements, and if this technology were to have played out now, would they be regulated differently? Probably, even though in the HCTP regulations, it does specifically say that this regulation is in effect for everything non-reproductive, for non-reproductive use. But as a side note, if you were to combine the practice of IVF with the gene editing, for example, okay, and you edit the genes, that is considered a drug. So that is where that boundary would overstep itself. But how have they done it? How did the doctors and the practice of IVF, which I think we'd have to look at the history, but I imagine OBGYNs were very much involved in this process of developing rules and the ways that this field is regulated.
I'd imagine the market dictates.
Yeah.
I mean, it's, you see clinics that are more effective and safer than others, and word of mouth. I mean, it's like any other consumer experience.
So the CDC has a fertility clinic reporting registry. And clinics must report their success rates to the CDC. Now, there are no direct penalties for non-compliance. So if you don't comply, it's not like someone's going to show up with handcuffs. But if you were running a clinic, you would want your statistics to be a part of this because it gives you the bigger picture of how these treatments are working, and also gives the consumer a place to go and check those rates out for themselves and decide which clinic they want to go to. So should the same thing happen in regenerative medicine? Like, is there low-hanging fruit in the field of regenerative medicine that should be accessible today that is not?
I would argue that the historical profile is comparable. I mean, we have more than 50 years of records of data and use of MSCs in particular, right? That certainly seems like a threshold for safety. And once safety is demonstrated and established, then personally, I would argue, yes, the consumer has the right to access, in conjunction with the insights and recommendations of their medical care providers, but has the right to access promising cellular therapeutics.
I would agree. So the treatment that we develop here are autologous and allogeneic mesenchymal stem cells. Now, these stem cells are readily found in our bodies, but if you were to pull up any scientific paper about the use of these types of cells, you will see always the same thing repeated over and over and over again. They have a great safety profile. Why? They've been used in thousands of studies with a great safety track record. So if we know that scientifically, we've documented that over and over and over again, now what happens is you have consumers that want access to this. They've read enough where they feel like this could help me, like I want to try this. But the only products that are available on the market are the ones that fit in these regulations. And therefore, by fitting in these regulations, like we've gone over in previous episodes, it's largely a bunch of fluff that is being sold on the market. And so that's what consumers have access to. If we don't open up the regulations to allow for safe use of these technologies by now inviting other players into the field that can bring forth better products that are probably more efficacious, then the market will never have a chance to even itself out. Normally that's what happens, right? You have technologies that are old and not as effective, and the market will start turning from it once they realize, oh, for the same cost, I can get this many cells at this quality. This is what I want. And consumers become more educated and start looking. But those options have to be available is the point. And so right now, I think the frustration with the regulations is, we go back to the purpose of these regulations is to ensure safety. But because of these, the access to safe therapeutics is limited. So we are creating a limitation for ourselves. And because of that limitation, you see patients traveling overseas many times to access what they think is better than what is available in the United States. And at face level, it is. It seems that way. At least if what they're selling is true, then yes, it is. It would be considered better from a numbers perspective and probably efficacy. But at the same time, there are so many unknowns. How are these products tested? How do we know that they're safe? You don't know. Where are these, birth tissues coming from? There's so many questions that are left unanswered, and patients take huge risks to travel overseas and get these products. Yeah. And also from an efficacy standpoint, we don't know what those outcomes are unless they're publishing their data, which I can tell you why they can't. So why don't you see more data coming out of these foreign clinics, it's because you have to imagine in a clinical trial, you have to standardize the data. Like if you're going to take a measurement of somebody before and after, you first have to be able to measure them, right? And so largely if you have a problem and you go to an offshore clinic, if your problem is resolved, you're not flying back there for a follow-up visit. So no one's measuring you after. So you see the problem with data collection. And also everybody's condition is slightly different because you're not enrolling in a trial with tight parameters of who's allowed to enter a trial and who isn't. And so you're limited in your ability to collect good data, which is why it just doesn't translate to a manuscript that can pass peer review, because it's just a bunch of anecdotal data points.
Well, I think there are also questions about consistency of the product itself. I mean, many countries that more kind of freely offer cell therapies do not have the manufacturing regulations that we do here in the US that require quality assurance, require testing, and establishment of what the product is, right? In that sense, I do think that, there is, and we've talked about this in previous episodes, but there is a degree of regulation in establishing that drug profile that I do find appropriate and helpful so that consumers know what they're getting. It's consistent, it's the same every time. But once that threshold is passed, what would happen if we let the market dictate?
Well, I think just like the IVF industry, we should have a reporting mechanism. Every clinic should be reporting what they're infusing, how many they're infusing. Really no different than sort of the right to try reporting requirements that are currently in play. Now, at some point, I think that those databases should be public information. It would be very interesting to see what patients are accessing and what the success is. In right to try, that there is no reporting mechanism for the success, but that can be something that is added to give us an idea of how these treatments are working. But from a safety standpoint, that is what they're monitoring right now. They're looking at all of these patients with all of these different conditions, accessing all of these experimental therapies, and what is the safety of that? That's what they're looking at right now. And I think we cannot operate on fear. If we operate with fear, we're really never going to get anywhere, right? In any innovation, there's always the first patient. Like some poor guy had to be the first one to get his chest cut open, right? Someone had to be. Someone had to be the first person to get a foreign kidney put into them, someone else's kidney. There are all of these medical advances that have occurred. And if we said, oh, we can't do this because nobody has done this before, then we really won't get anywhere. Yeah.
Well, and it speaks to the need, that people are willing to be the first. And we've had the privilege of meeting a number of them willing to be the first. It speaks to the need of real people in real chairs who are really sick. Yeah. And they want access. I'd be curious, we're talking about letting the market dictate. I really hope people chime in on the comments on this one and let us know what they think, because, our audience, you are the market. We are the market. The public is the market. And what do you think? What do you think about regulation? What do you think about access? How has it affected you? And if it's touched you personally, tell us about it. We'd love to know.
Yeah, please do. Please ask us questions and please give us comments. We'd love to have this discussion and see other viewpoints. We are sensitive to all of it. We know the importance of regulation. At the same time, we know the importance of common sense. And I think as a consumer, I would like access to more investigational treatments. I understand that our government through Medicare and Medicaid may not necessarily pay for these things because they're not proven, right? But just to be able to have access, I think is is something that we would all want. I can't imagine why not. I mean, it's not a situation where someone's forcing it upon you. It is your choice. Just like we as consumers have choices on anything that we buy, our medical treatments should be the same. And the information related to the quality of those medications or those experimental therapies are made available and in a transparent way that I as a consumer can make a decision on whether I would want access to that or whether I should try that. If I have a condition that has no other solution, then that should be something that is available to me. I would want that for me and my family.
I agree. That's why we're here.
All right. Well, next week we're going to end this topic.
Yes.
Yeah.
Yes.
Yeah.
Fourth criterion.
Systemic effect, and that is a loaded topic. Yeah.
Yes, it is. One that hits at the heart of definitions. Again, that's another theme. So, yeah, we look forward to it. I'll see you then.
Yeah. Stay tuned. Thanks, everyone.
Man's land.